Welcome back. We're going to introduce Dr. Bahloul now. Dr. Ahmed Yahya Bahloul is the medical planning manager at Dalla Health, bringing over 20 years of extensive experience in healthcare sectors. He is an accredited expert in healthcare quality and patient safety with credentials such as Certified Professional Healthcare Quality, Certified Professional in Patient Safety, and Lean Six Sigma Black Belt. Dr. Bahloul has contributed significantly to the national and international healthcare standards, serving as an expert with Sabahi for the development of hospital standards and training programs, holding a master in public health with a focus on health management and policy from American University of Beirut. Dr. Bahloul combined his medical background in cardiology with expertise in value-based healthcare delivery, medical recruitment, supply chain management, and hospital design. His commitment to innovation is further demonstrated by his expertise in data analytics and clinical documentation improvement. We are really honored to have you, Dr. Bahloul, joining us today to discuss reimagining and leading with value-based healthcare in the future. So welcome, Dr. Ahmed, and the floor is yours.
Thank you, Dr. Arwan. Thank you, Dr. Ziad, and all the respected attendees for this very nice event, actually, while it has been a weekend, but it is very successful and people are interested in this very compelling topic. So thank you so much for being here, and thank you so much for having me in this or such an event. So we will be talking tonight about the reimagining and leading with value-based healthcare in the future. It's a very fancy title, actually, and we will be indulged into value-based healthcare and its, pros and cons, limitations, challenges in Saudi Arabia and in the world as a whole. So if we can just go, this is me, and this is Michael Porter, the founder of the Science of Value-Based Healthcare, when he launched with the co-author Dr. Theisberg in 2005, Redefining Healthcare Delivery. And it's been a very interesting book and a very interesting topic. And since ever, actually, it's been in the healthcare market all over the world, not only in the United States. So we will be seeing today, is it a silver bullet? And actually, a couple of weeks ago, I had this seminar with the Shifa Al Orman Cancer Hospital in Luxor, Egypt, about the accreditation and value-based healthcare and how to integrate both into your day-to-day operations in your work. And this is really hard equation. It is not that easy to say. And I guess people with expertise with us tonight in accreditation and value-based healthcare just understand what I'm saying, but we will go deeper with the topic, inshallah. So just imagine you are going to apply, to be practical, to be pragmatic a little bit, apply a diabetes mellitus, which is high incidence, not only in Saudi Arabia, not only in the Gulf countries, not only in the region. It is like a pandemic as a non-communicable disease. And actually the health burden of this condition, diabetes mellitus, is very, very significant in healthcare systems. So imagine in your hospital, in your ambulatory clinic, in your setting, wherever you are, okay? So imagine you are trying to design the value-based healthcare model, like my respected colleagues last night talked about what's called IPU. IPU here means integrated practice unit. So you are just designing the services all around the patient, who is actually the center of the care, the center of the care. And by the way, we will be having this talk about is there any solution soon to what Dr. Ziad talked about his kids, inshallah, Allah bless. So we will be seeing and saying a lot about this when it comes to value-based healthcare and how to integrate this in our system. So diabetes mellitus, think with me, and you have the chat box. Okay, not QA, please, in the chat box. Just try to uh, design value-based healthcare model about the diabetes mellitus patients, okay? The main goal of our healthcare systems, the patients, or in the nowadays language, it is the health consumer, because there is a lot of consumerism nowadays. Consumerism means the patient now has conditions, okay? And while I've been working at Dalla, and Dalla at Nakhil, for example, is a VIP hospital, so there is a lot of consumerism. So we'll be seeing a lot of things. So now, who will be the carers of this patient in your hospital? So you are designing a diabetic center in your hospital or your polyclinic system. What do you think? Who should be there? Let's get started with internal medicine or endocrinologist, for example, or better to have a diabetologist, because since 15 years, I've been having diabetologists in my hospital back in Abu Dhabi, United Arab Emirates. So we are in the era now towards the subspecialties, fine specialties. So we have now diabetologists in Saudi Arabia, a lot. So let's get started. So we have a couple persons. So we have diabetologists, okay? And then who else? Nurse to help the physician who is trained in on diabetes mellitus, and whom else in this center? Just to try to imagine. Just diabetes, guys, huh? Diabetes, huh? Nobody in the chat. I can't see anybody responding, so okay. So let's see the slide. Okay.
Maybe we can open the chat, Athir. If the chat is not open to
Okay.
the
Okay.
attendees, maybe we can open it. Yeah.
Okay. Okay. So we will be thinking all together. So I guess we have here. Okay. Yeah. Nice.
I opened the
Yeah.
chat
Yeah.
now, Dr.
Podiatrist. Yeah. But yeah. It was closed. Sorry. Okay. So my contributors here are saying podiatrist. Thank you so much. Diabetes educators, dietitians, or even clinical nutritionists. Thank you. Diabetic educator, ophthalmologist. Okay. Yes. For fundus examination. Wow, interesting. And health coach. I loved it so much. We will be seeing now. Nephrologist. Thank you. Whom else? Guys, you have a lot of creative ideas, huh? Okay, pathology lab, clinical pharmacist, nice. Psychiatrist. I loved it so much. Psychiatrist, thank you. Psychiatrist or psychologist, not only social workers, but a higher level of professional practice in this area, because depression is a part of the process of diabetes, right? Surgeons for diabetic foot, thank you. For debridement, for above knee, or God forbid, yeah. Care coordinator, thank you. Clinical pharmacist, social worker, radiology. Okay, neurology, sarcoma. Okay, I didn't get that, but okay, sarcoma. Okay. Okay, occupational therapist. Okay, might be. Dentist, thank you. Bariatric. Actually, that's enough. Thank you so much. You have a lot of beautiful ideas. So we'll be just having a glimpse of some real case scenario and some, ideas. So we have diabetologists already. Okay. With full-time patient evaluation, diabetes educator, or with full-time patient education. So the physician and the patient educator and nutritionist and podiatrist can be all together in one team, one room with the patient, to just do the education, not just to go all together in silos, even within one center. Podiatrist, even for, dressings and Dopplers and a lot of things. Clinical nutrition or dietitian, social worker, psychologist, psychiatrist. Thank you. Fundus examination. Medical surgical referral for complications and other complications, like you've said, nephrology, neurology for neuritis, and so on and so forth. Wearables. We can just get some wearables or integrate the wearables, like the okay, the Apple Watch, for example, or whatever smartwatches, with, couple things we are collecting from the patient into our health information system. Gym classes in-house, or partnering with some, like somebody here said, health coach, yeah, and healthy cooking classes, and it can be like an incentive for our patients, in-house or outsourcing or partnering to provide healthy meals. And some hospitals now, big hospital groups, have like catering companies and so on and so forth. So yes, it's very nice. What about ACO? It stands for Accountable Care Organization. If you are a polyclinic, for example, and you don't have a surgeon, for example, for debridement, or you don't have fundus examination, proper fundus examination, because sometimes with the diabetic patients, it is not an easy job. So there is what's called Accountable Care Organization. We will be shedding a light tonight about it, but just noteworthy. So you are partnering with another center that is providing the care. The care you are missing at your center, this is ACO. Okay, so there is IPU even within ACO around the patient. We are designing the services for the compelling medical conditions or disease specific, like diabetes mellitus, in this order. We will be having this nice case. Actually, Dr. Nizar Munzer, ESG, I am a UB graduate, American University of Beirut, and I've been invited to this nice course in summer 2019. Last time I visited Beirut, and for what's called Summer Health Leadership Academy, and they invited Dr. Monzer Yazji. He's Syrian American, living in South Texas, and Dr. Monzer actually did couple polyclinics in Texas, and he's like a diabetologist, and he's dealing with the patients with diabetes mellitus in creative way in terms of value-based healthcare design and ACOs for extended or referrals needed for his patients. So with courtesy to Dr. Monzer, I took a couple of slides of his. So here he is dealing with nutrition, with healthy cooking classes within the center of diabetes, exercise classes, and every hospital has like a small gym at least in the physiotherapy department. So we can utilize this in order to provide like a gym class. Very simple exercises for diabetic patients, not to have any rigidity in the muscles, stiffness in muscles, or rigidity in the joints, or peripheral neuritis. Behavioral, like psychology and psychiatry, hormonal therapy, sleep. So they have like small sleep rooms if the patient needs some rest during the course of healthy cooking classes and exercise and seeing different care providers and so on and so forth. Okay. Multidisciplinary clinic, patient shared decision. So they are teaching the provider about the value-based healthcare and how teamwork is very important around the patient, and then set goals for the patient to follow, like a plan with metrics for every visit. So now you are visiting us. Did you achieve the goals we set last time? And those are the goals for your next visit in 1 month or 3 months, according to the acuity of the patient condition, and so on and so forth. So this is Dr. Munzer Yazji, and those are the teams. So here, full patient evaluation with other team members, not only the diabetologist, Dr. Munzer. And here is the patient education session with the patient and the patient educator, all together with the physician himself or herself, to provide the best care possible to the patient. And this is the care management team, okay, dealing with the patients, the calls, the appointments, the insurance, the claims, the data analytics, and a lot of other things, collecting the data when it comes to patient-reported outcome measures. We will be having a look on this as well. So this is a very fascinating example, and here is the sleep room, and there is a gym. Very simple gym things. Even in your dress, you came in with to your doctor, to the diabetic center, without any further requirements. Okay, so this was a very interesting example, just to give you a glimpse about what is value-based healthcare really. If we need actually to do value-based healthcare, not only talking about the cost, okay, to make the quality of life of our patients better and better, okay, and this will lead to loyalty to healthcare system and to your hospital or your polyclinic and so on and so forth. Martini Clinic, it's in Hamburg, in Germany, and this is very world-renowned center dealing only with one medical condition. Can anybody tell me? This is like a flag case study when it comes to Harvard, when it comes to value-based healthcare. Actually, it's Martini Clinic. And hopefully you can have a look at this case study online. So just tell me, Martini Clinic is dealing with what kind of, in chat box, okay? What the medical condition Martini Clinic, Hamburg, Germany is dealing with? Anybody has an idea? Nah. Okay, so prostate cancer. Prostate cancer, which is a very, very important or significant medical condition for males, especially in specific ages. And it affects really the quality of life of this patient. Okay. Yes, there is a good survival rate nowadays, recently, but still it affects a lot of the quality of life to those patients. So Martini Clinic, one of the best practices regarding the IPUs or integrated practice units or the value-based healthcare design around prostate cancer in the whole world. Martini Clinic, okay? Now, back to the basics. So this is Michael Porter, and this is Harvard Business School, where the all magic started back in 2005, an Institute for Strategy and Competitiveness. Actually, Michael Porter is not a physician, is not a healthcare worker anyway. He is a business professor. He is a competitiveness and strategy professor. But he came up with this value-based healthcare after thorough study of the healthcare system, especially United States, with all the problems of the United States healthcare system, because the historical build of the USA healthcare system is very complex, and you couldn't actually grasp why we are talking nowadays about value-based healthcare if you didn't understand the historical build and the existing status of US healthcare systems. You can find a lot of European, like UK, France, Germany, and a lot of other systems is better than US as a population health system or a public health system. You can go to Cuba even with a magnificent primary care after embargo by the United States in 60s of last century. Actually, they went towards primary care networks and it did great. Okay, so value-based healthcare in Michael Porter's definition is the very famous equation. Value you are providing to your patient over the cost incurred to this care all over different episodes to treat this medical condition. For example, you are doing cataract, you are dealing with diabetes mellitus patient, you are dealing with prostate cancer, lung cancer, you are dealing with maternity pathway, you are dealing with total knee replacement or osteoarthritis grade 4, and so on and so forth. So the value or the outcome you are providing or you are coming up with to your patients over the cost incurred in this kind of care. And please just download this from Google, okay? Please Google it. Never ask before anybody asks. Actually, please go to Google and value-based healthcare delivery by Michael Porter, okay? And just have a little look at this core concepts paper because Michael Porter is claiming in this small presentation, and there is, by the way, like 1 hour session on YouTube for the same presentation. You can listen to Michael Porter himself talking about value-based healthcare. So he is claiming, okay, and is one of the experts in the world, with all my due respect, but we will just have a look at the challenges and limitations as well on value-based healthcare. But it's a very nice thing because we tried a lot of things: evidence-based medicine, healthcare quality and patient safety, and medical error reportings, and electronic medical records, and Lean, and Six Sigma, and population health alone, and analytics, and big data, and care coordination, and so on and so forth. But those silos didn't work that well because there was no proper integration. So he's claiming this value-based healthcare is the glue or the silver bullet to healthcare system. Okay, and we will see. And this is the very famous equation. We will not do this again because my respected colleagues last night actually did great with this. And those are the six, building blocks of the value-based healthcare. Integrated practice units around the patient, IPUs, collecting data, measuring outcomes and costs, and bundled payment. And this is going on now on pilot in Saudi Arabia, and integrate and coordinate care across multi-site care delivery like ACOs, accountable care organizations, and expand or affiliate cross geography outside your city or governorate or محافظة or منطقة, whatever, okay, or even across borders, because some healthcare systems are across borders, and information technology. Okay. Now, some jargons, and I guess a couple of guests talked about it. CROMS, PROMS, PRIMS. Okay, never get scary because it's very simple. CROMS, it means the clinical team is collecting data from the patient or about the patient, from medical equipment, from the patient himself or herself, and so on and so forth. Those are CROMs, okay? Clinical reported outcome measures, simple measures, okay? Not that simple, actually, but some measures called CROMs, collected by the clinical team, mainly the attending physician, and it's called CROMs, okay? And then PROMs, the patient reported outcome measures. So the patient is, getting like a survey, paper-based or through SMS or WhatsApp or email, whatever, even through mail, through envelopes, like in the UK, and they are filling up those kind of surveys. It's called the PROMs. So we are collecting data about the outcome of the patient. So we did total knee replacement to this patient, and we are collecting data before and after, and like after a couple months, and like after 1 year and 2 years, and so on and so forth. So we are collecting data all the way to make sure the patient got the outcome required for such a procedure, and it enables us actually to collect data about the real costing of the medical condition. Okay. PRIMS, patient experience, okay? And patient experience, it's nice, it's beautiful, easygoing, but alone, it doesn't work very well in healthcare. It might work in, iPhone or something, but it has to be integrated with the CROMs and the PROMs. Otherwise, it is just patient experience. It's nice. The food is bad in hospital, we know, okay? But, CROMs, PROMs, PRIMs all together can, give us great idea about the patient and about our work, and definitely, finally, eventually, about the financial real costing of the procedures we are doing in our hospital. Financial costs, we will be not shedding that much light on because it's complex. Okay, so we need CFOs, and we need RCM, revenue cycle management people, and we need the exercise we are doing as a value-based healthcare professionals. It's called time-driven activity-based costing, like it is activity-based costing, if you are familiar with this concept, okay? And then in value-based healthcare, it is time-driven activity-based costing. I'll simplify this. You are measuring the time of your physician, excluding any waste in research, breaks, leaves, and so on and so forth, in the clinical duties of this physician. And for example, total knee replacement or osteoarthritis patients, you have this physiotherapist in the team, and might be the plaster technician for the cast. So actually, you are measuring the cost of those, excluding any waste, all over the year per minute, to be included in the final costing of the of the project. So this medical condition for this patient costed us so and so, specifically, including the healthcare workforce wages or costing per minute, okay, for such a procedure. For example, this procedure having like a pre-consultation before the operation, and then the operation itself, it can take like 2 hours, 1 hour and a half, 1 hour, but whatever. And then after the surgery, there is a visit while the patient is still in the hospital, and then there is a follow-up visit, and so on and so forth. So all of those, we are collecting the cost per minute for anybody in the medical care team providing the care to this patient. And then we are including this in the final costing, including the OR, the utilization of scopes, the consumables, and so on and so forth. All of those altogether will be the final costing of the medical condition of the patient, okay? Just to make things easy for now. So CROMS, PROMS, and PRIMS, it was like a heating debate 1 week ago on the Saudi German Health Value-Based Healthcare or Value-Centric Conference here in Riyadh. And it was my pleasure to be a panelist in this. And during my panel discussion, they were asking me, CROMS, PROMS, PRIMS, what comes first? And I've said to a lot of stakeholders, it is cost reduction first, okay? For the regulatories, for the healthcare provider executives, for even the patient needs the cost to be down, okay? Not to get rejections like Dr. Ziad faced with the healthcare system, and it is a very common thing actually when it comes to screening and preventive, and we will be talking about this at the end in terms of future, reimagining the future of value-based healthcare in Saudi Arabia and in the region, inshallah. Okay, so it's been a very heated debate, and but if we have to, order them, I'll be starting with the CROMs because the clinical team sometimes have to collect the data, even if the patient unconscious. So the patient has no role here. Actually, they are collecting the data. So we are collecting CROMs, and then for example, if we have cataract patient, a lot of CROMs will be collected from the equipment readings, not from the patient. The patient just, sir, I couldn't see very well like I've been before with my eye. So this is the complaint, and the medical equipment will do the rest, okay? And the readings will be the CROMs. And then PROMs, so clinical reported outcome measures, and then PROMs, the patient reported outcome measures before and after the surgery. For cataract, it's very straightforward, before and after data collection points, and that's it. And the PREMS is the patient experience. So forth. Okay, nice. Your room was clean.
يمكن دكتور جاه technical difficulty أثير.
Yes, doctor. I will check now.
اي والله check please ها. معليش شكل الدكتور أحمد he had a technical difficulty, so we will check with him now and get back. Just give us a minute or so.
Yes, he has a technical issue with the internet, and he will come back now. Yeah, he come back.
Yeah, okay, good.
Okay, so everybody can hear me and okay. And see my screen? Everything get back to normal?
Yes, everything normal. Yeah.
Okay, so okay. I have no clue what happened, but sorry for that. Anyways, so but I have here one fundamental thing when it comes to PREMS. When we are asking about the access to care, guys, it is not patient experience only. It is a system issue. It is a regulatory issue. It is payer issue. It's provider issue. It is everybody's responsibility about the access to care. Okay. And we will talk about this later on the reimagining at the end, like the recommendations, how to integrate value-based healthcare with other thing in order to improve the accessibility of healthcare, because value-based healthcare actually assumes that the patient has the access, and then we are doing value-based healthcare. But actually, when there is no access to care, we cannot use the value-based healthcare. Can you get that? Okay, and I guess everybody is having those kind of issues, okay, in nowadays life. Anyways, we will be talking later about this. So if we have to just arrange them, so crumbs at the base of the pyramid, then comes and proms, and then finally prems, but patient access to care, it is not only prems, okay? Okay. So this is redefining of access. It is not only prems. So Aisham, when it comes to CROMs and PROMs, and to a little extent PREMs, because PREMs is not main concern of value-based healthcare in the measurement. However, it should be integrated with a lot of PREMs. That's why ISHOM, which is International Consortium on Healthcare Outcome Measures, it is founded as well by Michael Porter, but that time, this time in the Netherlands, actually in Holland, okay, not in the United States. And you can go to this website and you can just have a look on, you can just do free account and download a couple ISHM data sets in order to look at the instruments and how to use it and the data collection points and so on and so forth. Some instruments need some license from ISHM, so you have to pay as an organization, or nowadays in Saudi Arabia, actually, or recently, Dr. Shabab Al-Ghamdi, the chairman of CHI, Daman, he signed a memo of understanding, MOU, with the ISHM president, Jennifer. So they will be adopting some prioritized ISHM data sets here in Saudi Arabia to be accessible to all stakeholders, plus the translation to Arabic, plus localization and contextualization to be targeting the population in the region in Saudi Arabia specifically. Noteworthy, by the way, measuring meaningful patient outcomes. It is a very nice white paper on the CHI website for free. You can just download it and have a look on the proms, and it's a very nicely put white paper. Now, comes to the second term, ACO. We've said in Diabetes Center, we have IPUs, Integrated Practice Unit, and we have ACOs. So if we cannot provide the service in our hospital, for example, you don't have oncology surgeon, for example, but you have medical oncology. So medical oncology now needs surgery. So you will be contracting as a hospital with another facility that can do the continuity of care. So this is simply put the accountable care organization concept, which was developed by CMS, or Centers for Medicare and Medicaid, the social health insurance in the United States. Okay, and this is a definition by American Association, Hospital American Association in America. And a lot of people doesn't know that Saha Holding Company 2019, before just COVID, actually they commissioned this playbook, ACO playbook, and it's a very well-written document, by the way, ACO playbook by Saha. And I'm very thankful to the team did that. Actually, it has been a very nice piece. Okay, so ACO playbook. And recently you can find this global review of accountable care organization published on the Saudi Health Council website. And it was jointly published with the World Bank. So it's a very nice document as well. So just some resources regarding PROMs, ACOs, value-based healthcare, so you can just have a good glimpse or grasp on the value-based healthcare. Now we come to the hard talk, okay? Value-based healthcare challenges, because value-based healthcare, as we started, it's a very nicely worded concept, okay, if we can say. And, there is like an aurora around it. So, yeah, value-based healthcare challenges. Let's get started with the first thing, patient access to care. If you don't have the access to your patient, actually you couldn't provide the value-based healthcare. This is simply what happened to your kids, Dr. Ziad. Actually, they didn't have the proper access. That's why there is no value-based healthcare, actually, because they don't have the access at the time, okay? So here it comes, the long time opponent of the value-based healthcare. So there are two schools within Harvard. They are just like opponents, okay? So Dr. Michael Porter, value-based healthcare in Harvard Business School, where I've been trained with him, and Chan Public Health School, okay? And I am, after cardiology, now I am a public health doctor. So population health comes in. And it's a big debate between Michael Porter and public health school. Public health needs access to essential packages of care for everybody under what is called universal health coverage, okay? Which is very hilarious to Michael Porter. No, okay, we need to focus on the patient needs the care. But value-based healthcare, okay, recently just got to realize there is a problem with the value-based healthcare, and the cost is still inflated because we didn't have proper prevention. There is no fluoride, doctors, yet. Okay, there is no pre-diabetic surveillance. There is no, good health surveys to get a lot of, insights in this. Okay. So population health integration has to be done with the value-based healthcare. And this is exactly what is been done now in the CHI, okay? A lot of things regarding the value-based healthcare, and along this, they have population health programs. Regulatory challenges, a lot of challenges, but we will not be talking about this in this talk. Providers, they have a lot of challenges when it comes to value-based healthcare regarding the bundle payment arrangements and pressurizing the providers, especially private providers, who cannot survive without insurance. Okay, mostly, oftentimes. Okay, so providers are in a bigger challenge, and a lot of other challenges will be coming ahead. So payers, they have some challenges, but they like the idea of bundle payment because it's gonna save a lot of money for them. Okay, like DRGs, like diagnosis related groups, but still they have a lot of challenges with the providers in this regard. Okay, patients. Where are the patients in the equation? Okay, so the patients actually should be the heart, the patient-centered care, okay, all around the patient. But still the patient has problems with access, has problem with the cost, has a problem with the rejections and the pre-authorization approvals and a lot of things. So patients have a lot of challenges. Technology, the integration of biomedical equipment, the APIs integrations, wearables integration. Okay, Big data analytics. We will be dealing with a lot of data points, actually, when it comes to value-based healthcare and population health altogether, and we have to have big data analytics. And definitely SAO transactions in data and money. Now you are contracting other providers, even other competitors, to provide the IPUs and the ACOs. Now you will be transparent with your money data and some of your data in your back kitchen. So it's a challenge. We have to face this, okay? We have to make it like a big deal when it comes to competition. And definitely supply chain. What's the value of the value-based healthcare when it comes to supply chain, and we have a lot of shortage in essential medicines and essential preventive screening, surveillances and equipment and accessibility to this, and so on and so forth. A lot of things. So a bit by bit, actually, we can overcome the challenges, but still, my concern about the first one, patient access to care. So we have to integrate population health with the value-based healthcare. Otherwise, we'll be facing a lot of problems. Okay, value-based healthcare is not only alone the silver bullet to healthcare system. Value-based healthcare future, how to reimagine this, especially in Saudi Arabia. Validated measurement instruments. Okay, and it's a big deal done now by Dr. Shabab and CHI guys. But still, we need to enforce organizations like ISHM and so on and so forth in order to come up with contextualized, validated measures we can use in terms of CROMs, PREMs, and PROMs. EHR integration, a lot of challenges are in there. We discussed this in the previous slide. So to integrate all of those wearables, APIs, biomedical equipment into our HIS or electronic health records, along with the CROMs and the PROMs and the PREMs. It should be shown in front of the physician and the care team in order to keep up with the patient condition. Otherwise, we are measuring in different platforms or in Excel or on paper, and it is different from each other. So what's the actually the deal here? Big data analytics, AI and machine learning for regulatory, payer, and provider all together. So we will be having a glimpse on this. Value-based bundle payment, it's coming, but a lot of challenges are in there, and we are in Dalla, we are piloting with CHI, and they are hearing to us and listening, but still it's long breath journey. Accountable care organization and ecosystem, like we've said, actually, we need to be transparent, but at the same time has our own privacy when it comes to sensitive data like financial data and some other kind of data. Value-based healthcare integration with population health management, the hard equation has to be there, Otherwise, there is no value in value-based healthcare alone. Value-based supply chain. So supply chain should be value-based, actually. The decisions based on data, based on value to the patient, what medications or equipment needed for diabetes mellitus patients, it should be based upon the value-based. Integration with all relevant stakeholders, other accreditations, KPIs at the Ministry of Health, Sahha Al-Qabida, Sahha Holding Company, and all of those in the kingdom, and Dr. Al-Khoja did great yesterday, landscaping all the stakeholders in healthcare system here in Saudi Arabia. So we need a lot of integrations. Otherwise, كل يبكي على ليلة. Everybody sings alone in silos. So it doesn't work this way, actually. And finally, public reporting for accountability. So those kind of, a lot of data, a lot of achievements have to be published, even in gray literature, white papers or so, or in the peer-reviewed journals like publications, because it is highly needed. And actually, CHI did with Statista and US Newsweek recently, especially with CHI Award launched recently, a lot of good work. Finally, science and research, definitely, like in parallel with public reporting. Now, big data. I have big data. Let's have a look just on Gapminder. I don't have that much time. So just we will be dealing with a lot of data. For example, Gapminder dataset by Hans Rosling, the great late population health doctor in Sweden. So just we need big data analytics like this platform, for example, people dealing with R, Python, Julia, and all of those kind of things to deal with a lot of data, have a look here with life expectancy and continence. For example, in this study started 52 in last century till to 2007. Here, the box plot for the continents and life expectancy, GDP per capita in every continent. So you will be dealing with a lot of data. It has to be there on a platform, on a very nicely put platform, okay? Here for violin chart, actually by group for life expectancy and continent. Yes, to make informed decisions, to have a look at your data from high level perspective, and you can go into details, of course. Correlation plots. So definitely you can see here the GDP per capita, very highly correlated, very deep blue with life expectancy. Otherwise, people are dying because they don't have enough money, so they don't have good access to good food, good life quality, and definitely not having good access to care. This very nicely put chart, but it's very complicated. We don't have that much time to explain, but the same from Gapminder analysis. So you need big data analytics. Just one code, just one platform. You can just pop up all the data or the correlations between CROMs, PROMs, PREMs, and finances of the medical conditions in value-based healthcare projects, or even population health management, if it is very well integrated, in order to have a look at those. Conclusion, I have only two lines of messages. One, value-based healthcare and population health management is part of healthcare future that can dramatically improve healthcare outcomes and contain the inflated costs. The second one and final one, Saudi Arabia can do better than USA in applying value-based healthcare and PHM, population health management. However, careful contextualization and implementation should be considered towards a pragmatic maturity. And this is my LinkedIn. Please honor me to join and under my name. And this is my YouTube channel. And thank you so much. Back to you, Dr. Ziad and Dr. Arun.
Thank you. Thank you very much, Dr. Ahmed, for such a very informative session. Didn't know if Dr. Arwa has collected some questions for Dr. Ahmed, so you can take the lead, Dr. Arwa.
Okay.
Dr.
So we have a couple of questions here.
Yeah, if you like to read them, or if you want to
Yeah,
have
I can read them on the screen. So we have a couple of questions. What should we do if we don't have access to certain services? How will we measure the value? I guess I shed a lot of light on this. So value-based healthcare couldn't deal with the access of care actually so far, but population health has to be integrated in order to improve this a lot. And CHI and the new HIA, the new insurance authority, will be having like a great role on this, okay, in communicating with the payers, of course. Will moving healthcare to a value-based model in future help to provide equitable, affordable, and high-quality care for all patients? All patients, I'm skeptic. Okay, still we have this access to care issue to tackle, but eventually it is long-term journey. Okay, it is not like 1 month, couple months, 1 year, 2 years projects. It can be taken longer, as any new project deployment, like health insurance, for example. It takes like minimum or an average 5 years to see like results. What are the importance of having solid HIS? I guess it's a very wide question, but it can provide a lot. If you can integrate CROMs, PROMs, PREMs, and eventually the ERP you are using with the HIS integrated, so you can just capture the finance data as well, you can do just a great. Dr. Ahmed, Ahlan, Dr. Nafa, what is the best start for healthcare providers? Is there any roadmap? I guess we started, Dr. Nafa, at the beginning with sort of roadmap for anecdote of Diabetes Mellitus Center. And but I know actually there is a lot of things to go with, but you can just have a glimpse on the Martini Clinic case study, and you will be benefiting a lot, inshallah. So, Dr. Dipsy, results of value-based healthcare in US today, any changes in outcomes? Yes, sure, dramatically. In outcomes, it's magnificent. It's amazing. Okay, so but I am telling it needs time and efforts, and a lot of challenges are in there. So you have to be just patient. Okay. Consumerism and value-based healthcare. Okay, but good news that consumerism usually on the cash side, oftentimes. Okay, so, but yes, it inflates the cost, but it's cash based because plastic surgery, dermatology, cosmetics, and so on and so forth. Any active VBC projects started in Riyadh? Yes, sure. We a lot of big hospitals here in Saudi Arabia, including Dalla, alhamdulillah, we are doing great with some pilots. A couple of projects with CHI, some consulting firms, and some payers as well, and so on and so forth. Okay. Anything else? I guess we are done.
I have a question, Dr. Ahmed,
Yeah, please.
because I really want to take your opinion on this. It has been discussed, I would say, a few months ago with a couple of colleagues. We we met each other at Sabahi, if you remember, Dr. Ahmed. So that's maybe why I want to ask you personally this question is. To what degree can the standards be updated to serve this transformation? I know that this might be a bit of also a question that is it's what I know recently is that the JCI have updated significantly on outcomes, and they are really focusing a lot on outcomes. I believe even Magnet has worked previously, which is related to the nursing part about outcomes, especially on benchmarks in certain indicators. But where do you think this is going? How can Sabahi, in particular, all the national standards serve into this massive transformation?
Okay, very, very smart and nicely put question, Dr. Ziad. And as you, as an experienced surveyor, actually, CHI as well did before standards for providers and payers. And still, it's a learning curve. And they respect this, and we are, as providers, respect that, and payers are respecting this as well. However, it has to be integrated, okay? Still, we are facing the problem of fragmentation, Dr. Ziad. So, Sabahi is a very well-known entity, and I've been privileged to work for them like 8 years in the headquarters of Jeddah and Riyadh. And they did great. They leveled up and nobody can deny actually the quality systems, especially in hospitals. Okay. Some other extents in ambulatory and primary care and labs, but basically in hospitals now people can talk standardized language, if we can say. The same, I hope, between the value-based healthcare stakeholders in Saudi Arabia, especially there is a commission or a committee on high level, commissioned by CHI a couple of years ago, even before COVID, regarding value-based healthcare. So, and Sabahi is a main stakeholder in this. And it has to be integrated, efforts between the different stakeholders in order to come up with what is really benefiting the patient, considering the challenges, considering the existing status of Saudi healthcare system transformation. Okay, because the problem in health policy, and my major in American University of Beirut was health management and policy. So health policy is one of my interests. So one of the limitations of health policy or any public policy in the whole world, it is a blunt end. Blunt end, it means I'm sitting now on this entity that has the authority to pose a set of regulations or set of standards for the providers or payers or whatever, okay? So I'm doing this, no problem, and nobody can blame me. I'm doing my job, okay? But one size doesn't fit all. And in health policy, we have to consider this very much. Yes, it is complicating things. It takes a lot of efforts and expertise and subject matter experts, but it really works. If we, for example, simple example, Dr. Ziad, and you went through all Saudi Arabia, all the hospitals, and you've seen the disparities between the different healthcare sectors and different regions and different sizes of hospitals. For example, there is a big difference between Ministry of Health hospitals, different sizes, and National Guard healthcare system, Minister of Defense healthcare system, Royal Commission, private providers with a lot of fragmentations and so on and so forth. So one size doesn't fit all. And what works for Dalla or Al Habib, it doesn't work for a lot of other private providers as well. Okay? The same for providers, the same for our patient segmentations. So a lot of work, actually, a lot of dialogues has to be there, a lot of healthy discussions and debates and arguments and evidence and research and studies, you know, in order to come up with what really fits the context of a great country like Saudi Arabia. Otherwise, a lot of efforts, and it's great alone, okay, in silos, but when you come to integrate all of those efforts, it might not work that much.
Thank you. That's I highly agree with this. Thank you very much, Dr. Ahmed, for your very informative speech and for your time answering the questions.
My pleasure.
We would like to move on for Mr. Faris and Dr. Hussein, who will be talking a little bit about something